or the wonder drugs, are used for a wide spectrum of conditions due to their potent anti-inflammatory effects, and that too chronically. Dr. AMEYA JOSHI, our next faculty, will guide us on care of a patient on steroids, exogenous Cushing's. Sir is the Secretary of Maharashtra Endocrine Society and practices endocrinology in Mumbai. The chairpersons for this session are Dr. Vineet Sabu, who has a special interest in diabetes in young, obesity, diabetic foot and nutrition, and who is practicing in Amravati since 7 years. We also have Dr. Sameer Sada as our chairperson, who is a practicing rheumatologist in Akola. I welcome our chairpersons and request them to please occupy their seats. Over to you, sir.
Thank you, Namrata. I think we'll start with session. We are running short of time.
Yeah. I think 3 organizations made this update possible. That is Maha Society, AMEYA Akola, and API Akola. Similarly, 3 people worked the hardest to make this possible. And I think that is Dr. Swapni, Dr. again, and Dr. Zubair. I think 3 cheers to all of them. They did all the hard work, really work. And thank you all of you for staying back so late evening for this today's endocrine update. Now, when you look at these words, close your eyes and think what comes to your mind. Sitting in an endocrine update and club 2 words, pain and pleasure. Don't think naughty. I wanted to take that topic. Madam said there is no demand for the topic. But I think here what we will be discussing about is that whenever you prescribe this particular medication called as glucocorticoids, the corticosteroids, you are giving a pleasure to a patient because they may actually be needed in the treatment of so many diseases, right from endocrinologists to rheumatologists to every damn specialty, including the COVID virus, only responded to glucocorticoids. However, whenever you use steroid ठोक दो, कौन सा ठोकने का ध्यान से ध्यान रखो. Whenever you are using a steroid, make sure that you look at this chart, remember it, and if you are using it as an anti-inflammatory, prefer something like methylprednisolone. Prefer something that is studied for that particular disease. If you are using for intracranial purposes, use dexamethasone. So these are broad choices. However, remember that glucocorticoids are the treatment. So if you want to please the patient, you have to also take care of the pain of the particular patient. Whenever you are using for treatment, use the shortest acting steroid that is studied, and that's why methylprednisolone is preferred over dexamethasone. Use of both of them are anti-inflammatory, better than corticosteroid, but methylprednisolone is shorter acting. And the third thing to remember is that if you are using it as a replacement, which is needed in pituitary and adrenal diseases, always prefer hydrocortisone unless you have a reason not to do so. And whenever you are using a steroid, if possible, therapeutically use a topical steroid. If that is not possible, use a pulse steroid. Most of the regimens are now shifting to pulse therapy, intermittent therapy. And if you are compelled to give it daily, prefer to give the largest dose in the morning. The reason for these 3 exercises is to prevent the suppression of hypothalamo-pituitary-adrenal axis. So whenever you withdraw the steroid, the patient doesn't go in a crisis. And 3 points to remember in any patient who is on steroids. That is, do not stop the steroids abruptly. Patient is taking steroids for a long time, band kar diya, patient is back in an adrenal crisis. You think you have done a noble job, when uska steroid band kiya, patient is cursing you left, right and center. And if he is not in senses, the relatives are beating you left, right and center. Always remember that if a patient is steroid dependent and is sick, you have to escalate the doses. And any patient on chronic steroid therapy, monitor 3 things: glucose, blood pressure, and electrolytes. Always remember that. And there is a golden savior 3 weeks rule. So whenever you are going to give steroids, try to give it, if you are giving it therapeutically, for not more than 3 weeks. The COVID guidelines said 7 days. We overdid, we got a lot of complications. So 3 weeks rule always stays. Your backup plan, if you are planning to give it for say some rheumatological problem, it's always better to start a disease modifying agent, try to taper the steroids, try to minimize the damage. But let's start with only one clinical case which I will be discussing throughout the talk, and that's of a 54-year-old lady walking into the OPD saying that doctor, far वजन वाढता है. It pains, whenever I get up, खूप दुखतं. I cannot even climb stairs. 4 पायऱ्या काय चढायच्या, she couldn't even climb the examination table. So there was a lot of proximal muscle weakness. She was gaining weight and there were stretch marks that were coming on the tummy. She said there is a little high glucose, and sometimes I feel like there is a chakkar coming, and then my BP is checked at a clinic close by and it's always recorded low. So she has been having these symptoms of body pain, stiffness, tiredness, every morning getting up in a disaster, and there was a savior. And that savior was a pharmacist. So go to the particular medical shop, get a particular tablet or an injection, आणि ती गोळी घेतली की जीवात जीव आला. So even if you try to stop it, त्या डॉक्टरांनी सांगितलं बंद करा, पण ते डॉक्टर नाही जमले, फार्मासिस्ट मात्र चांगला आहे, एकदम मी तरी होऊन जाते. And then now this is the other history that she had actually fractured a couple of years ago for a trivial trauma, and there is no other concomitant history in the family. The examination is quite clear. She is Cushingoid, moon phase, buffalo hump, little low blood pressure. Cushing's has hypertension if it is pituitary origin. If it is exogenous, you will have hypotension because of episodes of steroid withdrawal. And severe proximal muscle weakness. She was finding it difficult to typically walk. And then I told her, Madam, I want to see your wonderful tablet because even I am not aware of something so magical. And then she came up with this. That's dexamethasone. She was taking it left, right, and center whenever needed. And now we have a double bouncer. Why does she need dexamethasone? What to do with her now? So we did further investigations. You can see that she was mildly anemic. The high total leukocyte count is a steroid effect. But what strikes you is the typical postprandial rise in sugar against steroid-induced hyperglycemia. And you can see that her cortisol and ACTH levels are low. So finally, we decided to do some more tests because she was having a lot of pain, and the RA factor and anti-CCP came strongly positive. Patient. So I think always body pain needs a rheumatologist opinion, please. So then she was sent to our rheumatologist. However, her diagnosis is now totally changed. She was indeed having rheumatoid arthritis. Her aches and pains were genuine. The disease needed treatment, but we also needed to incorporate a plan or a vision to remove the pain part of the treatment. So she definitely needs both. So when she was referred to a rheumatologist, he said that okay, we are willing to put her on a disease modifying medication. We can taper her steroids gradually, not abruptly. Cortisol is low. She needs a care of 3 main things: bone, eye, and metabolism. And finally, she needs a care during steroid administration and steroid withdrawal to prevent a crisis. So the rheumatologist said that okay, let her be on methotrexate and hydroxychloroquine. Prednisolone I need only for 3-4 weeks. After that we can sit together and decide what is to be done. However, now the main issue comes. What to do for her bones, metabolism, and eyes. So let us start with the bones, because bone pains, muscle weakness, main symptom. So before we move on to addressing these things, always note patient's height, patient's weight. In a child and an adult, it's important to note height because The commonest reason why steroids cause backache is vertebral fracture. A short height is always ringing for a disaster, and any child never ever stop monitoring growth if the child is on steroids. You have to monitor the BP, the glucose, the bone density. So these are the broad things that you should be taking a stock of. Ideally, any patient who is being started on glucocorticoids after 40 years of age needs to undergo a test called as DMD by DEXA. Do it at your convenience if it is not immediately available, but keep it in your mind. Inform the patient that I need this particular test because I need to help you out for protecting the bones. Get an X-ray of the lateral spine if you cannot get an X-ray immediately. If there is a fracture, the treatment is different than what we are going to discuss now. So that's important to at least get an X-ray of the spine laterally. You should also assess for metabolism, the glucose level, the dyslipidemia, and the fracture risk of the particular patient, which we assess by FRAC score. I would request that next time whenever you have an endocrine update, tell madam. One is hypogonadism, testosterone replacement she has to take, and second is osteoporosis. So this is something called as glucocorticoid-induced osteoporosis. The commonest reason why, other than post-menopausal osteoporosis, the bones become weak is because of this single medication that is abused left, right, and center. That's glucocorticoids. And how small a dose can occur? Even 2.5 milligrams of prednisolone used for more than 6 weeks is going to cause bone weakness or bone loss for minimum next 4 to 6 months. And if you look at the fracture risk also, the mere increase in the dose from 2.5 to 7.5 almost doubles the fracture risk of an individual, and most of the fractures are crippling spine and hip fractures, which are as bad a prognosis as a heart attack. So what will you be doing? For every patient on steroids, the patient has to receive calcium and vitamin D. Any patient taking steroids for more than 3 weeks, calcium and vitamin D has to be a part of the regime. And it's mandatory that you prefer or offer the patient an option of getting a DEXA, at least get an X-ray of the lateral spine and assess the fracture risk of the patient, because even if you are going to give him the weakest medication as a prophylaxis, if he has a fracture, you may have to give him a stronger medication like teriparatide injections to heal that fracture. Secondly, calcium and vitamin D for all, but anybody above 40 years of age needs more than calcium vitamin D. So if somebody on steroids come to you, doctor, what could I do? Okay, for your bone weakness, take calcium vitamin D. Don't stop there. If you are giving the steroid more than 3 to 6 weeks, a minimalistic approach says that you should give him a medication called as bisphosphonates. How long? At least 3 months after stopping the steroids. What if there is a vertebral fracture? Change gears, shift from bisphosphonates to teriparatide or something called as denosumab. How long to give? Probably 3 to 6 months after stopping the steroids you have to give. And bisphosphonates are economical, easy, weekly tablet or a monthly injection annual injection is good enough. So always look at the patient, keep his bones in mind, look at how old is the patient. Our lady is post-menopausal, so if she has severe osteoporosis, we will consider higher treatment. But remember, calcium for all, anti-resorptives for people above 40 or below 40 on a case-to-case basis. We let the endocrinologist take a call. So we did what we discussed for the patient, told the patient you need to get a BMD, you need to get a BMD every 2 years because rheumatoid arthritis is a risk factor again for osteoporosis. And remember to continue calcium and vitamin D forever because she is post-menopausal now. And start with alendronate, the basic bisphosphonate. She did not have vertebral fracture. Basic bisphosphonate, 70 milligram once a week. Take an empty stomach, full glass water, not to eat, drink or lie down. So whenever you give bisphosphonate, not to lie down for 1 hour after taking the tablet. Always steroids will cause weight gain. And most of the times the patients will end up with mechanical issues. difficult to walk, muscles are weak, bones are also weak. Sensitize the patient that they need to follow a diet. Patient on steroids has to be protein replete. You know what happened in COVID? Glucose levels started rising. We were puzzled what to do. Because the patients were on steroids, we started giving them protein rich or at times very carb deficient diet. And not only did it help them cope up better, it also helped us manage their glucose levels better. So it's better to give them, ensure at least 1 gram per kg, if not more, of proteins for patients on steroids, and tell them to exercise regularly, maintain the muscle strength as much as possible. Now, moving on from metabolism to glucose, an important part of metabolism. Any patient coming to you, you are planning to start steroids, at least do an HGP, tell the patient to get a fasting and post meal. Important because 3 हफ्ते बाद शुगर करके आएगा, डॉक्टर अपने ही डायबिटीज दिया. So then you have to have a particular communication. Okay, your sugar is like, you are currently like this. He may actually be diabetic. And if not, tell him that 48 hours later, again do your glucose level, let me know. Stable patients on OPD basis, most of the times can be managed by metformin and DPP-4 inhibitors. Overall from COVID, DPP-4 inhibitors have got more preference in management of steroid-induced hyperglycemia. But most of the patients will actually need insulin, especially if they are unwell. So if somebody is hospitalized, it's always better to give insulin. Look at these 3 figures very carefully. If the patient is on hydrocortisone, short-acting steroid, short-acting insulin. If the patient is on prednisolone or methylprednisolone, something like insulatard or mixtard, intermediate-acting insulin. Somebody who is on dexamethasone, more than 24 hours action, needs a long-acting insulin like glargine, and then you can give bolus doses based on the pre-meal sugar. This is one algorithm. As I said, I myself will share the PPT with madam. I try to see how many of our speakers agree to it, and we try to see that, whatever deliberations have been there, at least a part of them stays with you as a memory. So, the management at a glance. In an OPD patient, you can use OADs, DPP-4 inhibitors, alpha-glucosidase inhibitors, once a day insulin. IPD patients, best is to put them on a basal bolus insulin, because IPD patients, we have to give a best result, as well as tight glucose control is needed. Third part, we learned about bones, we learned about metabolism. Third is eye. 3 things to look in the eye. Cataract. Cataracts are much more common in steroid users. Glaucoma. Raised intraocular pressure much more common, and retinal changes. So 3 things that ophthalmologist must check. Ophthalmologist के पास भेजा तो मुंबई में भी लोग केवल नंबर चेक करके आते हैं. They don't go to an ophthalmologist. So always mention these 3 things. If they are there, I will accept. If they are not there, I will ask you to go again and get all these things in writing. Then only we move ahead. So coming back to our case, she was started on calcium, she was started on vitamin D, alendronate. Her glucose levels, because she was OPD patient, mildly diabetic, sitagliptin, metformin was given, and she had actually had a cataract for which she was made fit for cataract surgery. Now, what care to be taken? The third and the last aspect of the talk. Because she is going to undergo cataract surgery, any surgical procedure, tell the patient he has or she has to take a bolus of IV steroid push. 100 mg hydrocortisone before a cataract surgery or a dental extraction takes care of a small stress. For a bigger surgery, 15 milligram 6 hourly or something like that hydrocortisone can be given. Now, what if the patient is at her home? She is now on a maintenance small dose of steroid. She suddenly calls up, doctor, I am having cough, cold and fever. What is to be done? Tell her to double the dose or triple the dose of steroids. अगर अच्छा नहीं लग रहा है तो 2 दिन बाद इसको 3 गुना तक कर दो. If you are taking 1 tablet, try to take 3 tablets a day. So that is what we tell the patient for a OPD basis care. Obviously, anybody coming in crisis, you have to manage, and tell all the patients. If the patient is non-diabetic also, but now has become sick, check your glucose, check your electrolytes, monitor your BP. Anytime unwell, don't sit at home. Come to the emergency. You will get hospitalized and treated, because they worsen and go in crisis very fast. Now, any patient who is on steroids, especially children who are taking replacement doses, any adults who are with Addison's disease or long-term steroid like our patient, needs to have a steroid card. Imagine such a patient going for some tour, वो गोली को भूल गए, 2-3 दिन हो गए, चौथे दिन she has collapsed. She has to be rushed to the hospital. So the hospital treating doctor finds this, immediately gives hydrocortisone, patient is on her feet. That's wonderful. So always carry steroid card for patients who are steroid dependent. Now we have done a wonderful job. Gave a patient a care plan, managed all the complications. Now the patient says, doctor, आता खूप चांगला है, आता ही गोळी बंद करा. So what to do? You have to do a serum cortisol level. Give prednisone in the morning, then next morning when you check the blood sample, do it without taking prednisone. So 24 hours, no medication to avoid assay interference. Check the cortisol level. If somebody is on dexamethasone, shift to prednisolone, then do a cortisol level, 24 hours gap. If the cortisol level is beyond 18, stop the steroid. If the level is between 9 to 18, so usually if the level is above 9, you can safely assume that patient can still cope up. Normal level of cortisol is between 5 to 20. If it is above 9, you are again good enough to stop the steroid. But if the level is between 3 to 9, if it is below 3, no stunts, please continue a maintenance dose. Between 3 to 9, do something called as synaptin stimulation test. There is an injection called as synaptin. Give that injection, 1 hour post that injection, check a cortisol level. It has gone above 80. Fantastic, patient can stop. I am repeating, below 3, not to stop steroids. 3 to 9, inject synaptin, do 1 hour post synaptin cortisol, above 18 stop. Above 9, reasonably sure because synaptin availability is again an issue. So in our patient, we tapered the dose, kept a minimum dose, then we saw that the level is little improved, then we gave her an alternate day dose in a guarded manner, told her that sickness we have to increase. Few days later, her cortisol level came better. We stopped prednisone. She is now very happy with the treatment that's given to her with methotrexate and hydroxychloroquine. Rheumatoid arthritis is also quite stable. So let's have a quick recap. So glucocorticoids may actually be needed to treat the disease. If you have a disease needing the treatment, want to give the patient pleasure, always be prepared to take care of the pain part of it. Try to use the shortened dose whenever possible, and if you are giving as a replacement, like in Addison's disease, prefer hydrocortisone. Whenever giving for therapeutic use, topical steroids, alternate day therapy, and if you are giving daily, biggest dose to be given in the morning. Never stop glucocorticoids abruptly. Always remember crisis management and always take care of glucose, blood pressure and electrolytes. Most importantly, if the steroid needs to be continued, check for bones, metabolism and glucose. Ladies and gentlemen, thank you one and all for your patient listening. Thank you once again.
Very informative and elaborative talk, sir. This issue of steroid-induced hypercortisolism is very prevalent in our OPDs. We face many patients who are dealing with this thing, weight gain, moreover skin rashes, dryness of skin, mood swings. So you have covered all the points very well. Any questions from audience?
I have one quick comment to mention. There are many patients who are taking alternative medicines for rheumatoid disorders. Dr. Samir will agree. Those are actually Dexona tablets or any steroid tablets mixed in some powder, and they are taking that. That is actually Dexona. If you do basal cortisol, you will get to know that cortisol actually is suppressed, and you need to refer those patients to endocrinologist or start tablet doses of steroids. Otherwise, patient will end up in adrenal crisis. That's it.
Dr. Satish Rivani, to please come forward and felicitate